free to use the chat box, and we will navigate that as best we can, or you can raise your hand with a little hand icon. And we will have some time, hopefully at the end, where we'll unmute everyone and people can engage that way. And then finally, once the webinar is over, again, we just ask that you please take our survey, and then we will send out certificates of completion. So I'm going to now hand it over to our presenter.
Oh, thank you. Hi, I'm Mark Pedrotty. I'm a rehab psychologist here at Carey Tingley Hospital, and I'm on the board of the Brain Injury Alliance of New Mexico. And my co-presenter is?
Hi, I'm Joanna. I'm one of Mark's interns and students, and volunteer for the Rape Crisis Center. Went through a 40-hour training with them. Learned a lot about the link between domestic violence, traumatic brain injury, and how traumatic brain injury makes one more susceptible to be victimized. And I've done a lot of research into the Barrow Neurological Institute in Arizona, which is a program that we would love to sort of recreate here in New Mexico. So I'll be talking about that later.
Thank you. Okay, so the format is I'm going to go through some slides, and I think someone's going to kind of keep track of the slides, because I think if I'm doing the share screen, I can't see this the chat. So we're going to basically do chat. I think I can figure out how to get chat up. Yeah, there it is. So I'm going to fumble around a little bit, but you can use chat to ask questions, and then we can interrupt as we go. And so some of this is going to be just a basic on, first of all, I want to say I have no disclosures. So the objectives are the basics: identify types of brain injury, identify outcomes of brain injury, identify relationship between brain injury and domestic violence, and identify several interventions for brain injury. So we can begin to talk about how does this all go together and what do we want to do moving forward. So sometimes I talk too fast and someone can flag and say slow down or something. And I'm going to try to get that box to show up again. It comes and it goes. So this is, it's a picture of a tattoo of the human brain. But basically, it's about 10 pounds, and it's a kind of a very soft mass, and it can be injured in many different ways. And where the injury occurs is important. So to the left of that picture is the frontal lobe, and that's where our executive functioning is. And to the very back, that kind of more lined kind of place in the bottom is the cerebellum and the brainstem, and that's the part that does your breathing. And if you take that out, you die quickly. And just above that in the back is the occipital lobe, that's your vision components. And then on the side, crinkle part is the temporal lobe, and that has to do with a lot of your memory. And then parietal lobe has to do with some of the visual planning kind of components. So in the US, in 2013, there was TBI contributed 2.8 million emergency department visits, hospitalizations, and deaths nationwide. So, and then the rates of TBI-related emergency department visits in the United States increased. I have to move this box, sorry, someplace. Increased by 47% between 2007 and 2014. And in the US, the leading causes of TBI are falls, followed by being struck by or against an object, such as in domestic violence, and then motor vehicle crashes. And so there are between 3.2 and 5.3 million persons, about 1 to 2% of the population that live with a long-term disability from a brain injury. And these are what they think are underestimates of the prevalence of TBI in the country. So here in New Mexico, we use this a survey to try to estimate how many people in New Mexico have TBI, and we're talking about trying to get the state to do more surveillance. So, but at this point, if we use what we think, there's probably 369,000 adults in New Mexico who've had a TBI with loss of consciousness. And again, you don't have to have a loss of consciousness to have a TBI, so that's an underestimation. But if you do have loss of consciousness, then that usually kind of says you had at least a mild brain injury. And then there's about 60,000 adults who are in need of services for TBI. So that's a fairly big population. And then just from a counting point of view, that we know that were hospitalized, there were 5,000 people were hospitalized as a result of a TBI in New Mexico over 4 years, 2012 to 2016. And that's an incident rate of about 4.8 per 10,000, with the highest incident rate among the elderly at 6.7 for the 75 to 84 group and 32.4 for 85 and above. And as you can guess, that is basically falls. Older people are falling a lot, and that's why in the state there's an education program on trying to prevent falls in the elderly. So here in New Mexico, the leading cause of TBI death is a little different than from the nation. And so firearms ranks #1, and then falls is #2, and then other injuries are 3, and motor vehicles are 4. So it does have something to say about what do we want to be doing about firearms in New Mexico. So now domestic violence and brain injury, that's what this talk is really based on, is important to begin to explore. And I think hopefully most of you have seen the talk on how brain injury occurs through strangulation, because that's essential, and it's a very important part of the domestic violence experience. So from one study, 75% of 99 women, so that if you call it 100, so that's about 75 women out of 100 who sustain interpersonal violence, sustained at least one partner-related TBI. And then 50% of those 99 women who sustained interpersonal violence sustained multiple partner-related TBIs. And then brain injury severity was negatively related to measures of memory, learning, and cognitive flexibility. And those are things we'll talk about in a minute. When you have a brain injury, things start getting worse from your cognitive functioning. And then many women suffer from repetitive mild TBIs, such as in the form of anoxic or hypoxic from strangulation. And so this repetitive TBI component is really important, because if you have a brain injury, the suggestion at this point is you'd like to have like a year in between your brain injury so your brain can recover. And basically, the belief is that brain injuries are what's called additive. So as you continue to have brain injuries, your cognitive functioning and things are going to worsen. So it's really important to begin to track how many brain injuries people are having and helping them prevent further brain injuries. So just a quick run through on brain injuries. There's types of mechanisms of brain injuries. One is just a blow to the head, and that's if you just get hit like on one side of the head or something, or the back of your head. You can get a brain injury from there, and sometimes people's skulls get cracked or something. But then there's a interesting phenomenon that happens because the brain is in a case, just like the yolk of an egg is inside the egg. And so when you hit the brain on one side, it then moves forward, and then it's going to hit the other side of the skull. And so that's called the contra-coup. So the coup is the hit, and the contra-coup is the sloshing of the brain and hitting against the other side of the skull. So you begin to ask how many different parts of the brain get injured depending on the hit. Now, of course, there's the penetrating injury, like gunshots, or for people who play with nail guns and things. There's always a person who's the roofer who ends up with a nail in his head and wondering why he has a sharp pain in his head. But there's ways that you can have things that penetrate the skull. And then there's this thing, axonal injury, and otherwise known as DAI. And that's basically from rotational forces. So if you're in an accident and your brain is shooken a lot, and there's where it might get hit on side to side, it also is also spinning in some ways or rotating, and that causes tears as well. So it's kind of like the fabric of the brain. Those nerves, when they're being torqued, are just pulling apart. And so you're causing those neurons to begin to sever, and then those pathways begin to die and have some what's called toxic cascade that causes the brain to have to heal from that. And then the other form is the anoxic and the hypoxic, and those are the things that are part of the strangulation component, where if you're losing oxygen to your brain, then bad things start happening. And so strangulation, as we said, is one of that. And women of high risk for partner violence, up to 68% will have suffered strangulation. And then on top of strangulation is the part where the partner might be sitting on the chest. And some people think of strangulation as just grabbing by the throat and crushing the air pipe or the windpipe or the trach. But also if someone is causing you can't breathe because it's sitting on your chest, and things like that can also lead to strangulation. So it's really important to begin to screen for if you've had any sort of strangulation or any sort of brain injury in the process of the interpersonal violence. Then, of course, there's toxic, where you can drink too much or do drugs and things, and there's bleeds and strokes and things like that, and infection. And so you go from what's called a traumatic brain injury to a acquired brain injury, and we put those together because they both are types of brain injury. So the outcome of brain injury is fairly diverse, and each brain injury is a little different, so you can't just say every brain injury is the same. So there are changes in cognitive functioning, mood, sleep, social functioning, and independence. There are medical complications that can arise from it. There can be ringing in the ears, paralysis, chronic pain, headaches, vision problems, taste. There's many different things that can occur. And there can be an increase in suicidal thinking, and so people with brain injury can have an increased risk for suicide. There can be an increase in substance use, so they're at risk for that. Obviously, there's the fallouts of cognitive dysfunction, and that's the loss of a job, which then causes financial ruin. And then homelessness, it can be another huge problem, as well as you can be arrested for aggression, disinhibition, and things like that. So the duration of changes from a brain injury can be fleeting. You could clear in a few hours to a few days, or it can lead to a lifetime of change. And so trying to figure out how to help people recover as fast as they can and how much they can recover is important. And certainly, as we mentioned before, repetitive injuries worsen outcome. So one of the things there are screens for brain injury, and Joanna will talk about one of them that the Barrow Institute is using as well, and that's this one here called HELPS, actually. So, and if you look down the left column, it's HELPS. And so it's a screen that you basically train people just to ask the simple questions of, have you been hit in the head? Have you had emergency room treatment? Have you had a loss of consciousness? Do you have problems with concentration? Have you had any sort of illness or sickness or other physical problems following an injury? And this just gets you in the door just to begin to think about maybe you've had a brain injury. Another screen that's a little bit more involved it was developed at the Ohio State University by Dr. Corrigan. And it basically clarifies what's the worst brain injury you've had, what is the first brain injury you had, have you had multiple brain injuries, what's the most recent, and other sources of possible brain injuries. And I have a link here for you because they have put this into a webinar where you can learn how to do this screen. And it has some connections on understanding brain injury. And the Ohio State University has some wonderful resources on brain injury as well. So this is what the model looks like from an integration point of view for a brain injury, if you've had brain injury. And so let me just stop there for a second. Are there any questions? Because I can't find there it is, chat. Let's see if we can find the chat. Are there any questions at this moment? Should I just roll on, or chat? Okay, there's chat. Okay, so I don't see anything on the chat. Mark, if you mouse down to the bottom of the screen, you could, okay, got it. Thank you. All right, so that was helpful. If there are no questions at this time, I'm going to wait 10 seconds. If there's no questions, then I'm going to go on to some of the treatment issues. Okay. All right, then. So remember, if you have questions, either chat in or unmute. All right, so if you do have a brain injury, it can get really complicated really quickly, and there's a lot of people that can get involved in treatment. Brain injury can start with a concussion. And concussions, if you're lucky, will resolve in a few hours to 10 days and require some rest and then some activity. So you kind of just ramp back up and you keep track of your symptoms and hope that you get better over time. And if it persists after 10 days, then you really need to be thinking about some other forms of treatment to get it to improve. And then if it doesn't resolve after a few months, then you have a bigger problem on your hands and other interventions would be necessary. So after the mild concussion or the concussion or the mild TBI, then you get into the more either mild TBIs that linger longer and have more problems, or moderate and severe TBI. And then you're into an integrative rehabilitation model. And so we use what's called the biopsycho cognitive, social, and spiritual model, if you're familiar with that stuff, because there's so many different components to it. And there's all these people that are part of it. So there's the medical health professionals, the rehab therapists, which is a speech OT, and PT therapists. There's the psychologists and counselors, which we're trying to hear through the Brain Injury Alliance in the university. We're trying to get more counselors trained. So if all of you have any people who are interested in the counselors who are interested in learning how to work with people with brain injury, let me know, because we have an ECHO that meets every other Wednesday, and it's free, and it can help people learn to work with people with brain injury. Social work is essential for the services and support they might need in applying to disability and making sure they get the correct diagnosis for the brain injury. Information technology is important for all the supportive services they might need. Support agencies, obviously the person living with brain injury, family, school or work, and the community are all important elements. So the importance of identifying TBI among people living with mental health and substance abuse issues has been shown. And so basically the research is showing that there's a group of people who are in therapy and they've had brain injuries, and they would do better if they had the brain injury identified. And that's been shown in the military as well as in the general population, civilian population. So one of the comments is that failure to detect TBI in people with co-occurring disorders who are seeking integrated treatment could lead to misdiagnosis and inappropriately targeted treatment and rehab. And identification, symptom monitoring, and treatment practice may require alteration and further special consideration in individuals with PTSD and substance use issues and TBI. And we'll talk about this in a minute. The literature on what to do with somebody who has post-traumatic stress disorder and a brain injury is really interesting, and it's mixed. Some people think that if you basically take care of the PTSD, then the cognitive issues go away. And some people say that you should do both. And so those are things that still the jury's out on, and it is important if you have PTSD to make sure you get that treated. And if it does make the cognitive issues go away, then that's great. But if the cognitive issues linger, then it's important to make sure you do those as well. So it's a wait and see kind of proposition. So this is the screen that I wanted to spend a little time with you all on, because this is the model that the Brain Injury Alliance basically is adopting, and we've been teaching on. And it's a complicated model, and it asks people to think about the different components of a brain injury and how it affects a person. So in this model here, the thing you see on the top is this thing called motivational interviewing. So if this was Hollywood Squares and I could see you all, I'd ask you all to raise your hand and say how many of you know about motivational interviewing, because it's important for many reasons when you're helping people figure out their readiness to change, and how to help them get to the place that you think they need to be. That's one of the keys to this, is that just because you know what they need to do doesn't mean they're going to do it. So I will go over that in a little bit. And then the question becomes, if you had a brain injury and you've also have psychological issues, depression, PTSD, anxiety, suicidality, those things, then how do you work together? And then the other thing is that if you also have substance use issues, then how do you work together as well? And so we've developed a model that basically allows a therapist to juggle 3 issues simultaneously in session to basically help a person with the brain injury get services instead of being told I'm sorry, we don't treat people with brain injury if you have a substance use issue because you don't fit our program or something. So after that, after you talk about the different cognitive rehab issues and how they all go together, then we basically ask, what does your brain injury look like? So on the left side of the screen, if you're looking at it, is what's basically a hierarchy of cognitive thinking. So on the bottom, you'll see STAM. That stands for stamina. So the first question is how long can you concentrate and do something before you're tired, get irritable, get a headache, or need a nap? Then on top of that is attention and processing speed, is what that is. And so what's going on there is how well can you pay attention, how well is your divided attention, where you can do 2 tasks simultaneously, how well can you remember numbers forwards. Everybody's password is now at least 8 digits. Can you remember that or not? And are you in trouble? Do you have to write it down? And then how fast can you do things? You'll see that some people with brain injury have what's called a slower processing speed. They need more time to do things. They need longer pauses and things. They need you to slow down because they're not processing. The next step up is working memory. And working memory is basically how much information can you hold in front of you on like a plate to begin to plan and do things and remember things. So some people call it short-term memory. Some people say it's active, so it's not short-term memory. But one way to measure it is just to say how many numbers can you remember backwards. So if I give you a number string 784, can you say that backwards? So can you do your phone number backwards? Can you do the alphabet backwards? Can you remember what the person who was talking to you said after you got done talking? So it's called an end back. Can you remember one piece back of what was said or two pieces back in the conversation? And so that's working memory. And those 3 things, stamina, attention, processing, and working memory, are attached to basically memory. So in order for you to remember things, you have to be able to attend, you have to be able to be alert, and you have to be able to hold some of that already kind of in a buffer to then try to then encode it and put it into a file cabinet. So memory is built on this foundation, and if the foundation is solid and you're still having memory problems, then you have to learn other tasks to basically improve your memory. If the foundation is weak, then you look at the weak parts of that and you work on those things and see if that helps the memory. Fluency is how fast you can read, and like a math minute, how fast can you do calculations. So when you're at the restaurant and they go, okay, what's 15% of $2 or $20 bill? And you're like, what? Now, as you know, we have this thing called external compensatory strategy, which is they tell you what kind of tip you should be giving them for the bill. So they're already like, we're not even going to ask you to consider this. Just pick one of these and write it down. And then if you have a party of 6 or more, guess what? They already add the tip in. You're like, what just happened there? So the first time I learned that, I kind of tipped them twice, and I was like, wait a minute now. So now I look for that. So fluency is how fast you can read and do things like math and things like that, just simple calculations. And sometimes that slows down a great deal. And then on top of that, the EXFN is a code for executive functioning. And that is a kind of how well can you plan and then do something and then evaluate how you did it, and how well you can inhibit responses. And so that's the frontal lobe. And if that gets injured, then things get really difficult. And there's 5 different types of executive functioning disorders that need to be looked at. But also, if the foundation of executive functioning, the stamina, attention, processing, work, and memory is not doing well, then you might be able to plan just fine, but you might need everything else slowed down and written down for you so you can plan from there. So as you can see, it gets complicated really fast because cognition is really complicated. And you want to begin to tease out where the injury caused the greatest weaknesses in the thinking, and then how do you work around that and then build it up again. So that's where the circles come in underneath on this picture, and that is there's these 6 here. There are 6 types of interventions. We're up to 8 now, but one is medication, another one is good sleep, diet, exercise, maybe acupuncture, maybe see a chiropractor, those type of things. Then there's cognitive training, where you can get on a computer and you can do some training exercise, or you can do it in the office with somebody depending on how you want to train. There's internal compensatory strategies where you're basically teaching people how to like remember or remind themselves to slow themselves down, or remember to ask people for questions, to repeat themselves and things, or to remind yourself to take a nap and things. So it's the things you're queuing yourself up to remind yourself to do, which, as you know, requires memory. So you have to kind of practice this stuff. And then there's external compensatory strategy where that's like your smartphone, right? So you have a smartphone, you tell your smartphone, I have to be in an appointment, so I need you to give me a reminder. You can use it to take your medications. You can use it for just about anything at this point, other than make coffee or bake bread, right? So, and then finally there's the environment, and this is where basically people who are in shelters and everything come in, and they're providing structure. There's two types of environmental strategies, is changing the structure. So like in my office, I have fluorescent lights, and sometimes I have to turn off the lights because they bother people who have eye sensitivity. So you figure out how the environment might have to be quieter or lower, or it might need a place to write things down, or it might need an alarm in it or something like that. And then there's the people in the environment who are offering the structure and support for the person who has a brain injury, and they're trained on how to interact. And then finally, we go through stages of getting better, and we talk about how it starts with surviving, where you're just sort of keeping yourself together and you're getting all the support, and then healing, where you start learning how to do things a little better and you're feeling better, and then basically generalizing what you're learning about how to do things better to your environment. So you then generalize, which is the biggest kind of leap and the hardest thing to do. And then at that point, then you're ready to kind of separate and go practice things on your own, and then begin to end therapy. So that's a lot to digest. Are there any questions about that sort of model, or me talking too fast, or anything else going on? Or are you all just enjoying whatever you're reading and just having fun, or what? I'll take a few seconds now and just allow for some questions if there's some questions. Okay, I've either put you all to sleep or we can move on. So either way, we can move on. Just remember, mute if you're snoring. Okay. Okay. All right then. So so what does this all mean? Well, let's see if we can get back to this. So this gets into some other stuff, and we might come back to this a little later, because I'd like Joanna also to talk about what the program looks like at the Barrows Institute and what else we're trying to do. But there's a fancy word. This is something that Linda Latch put together, and it's called the Developmental Metacognitive Approach. And so we're talking about helping people heal from brain injury. This is a nice framework we use. And as you can see, it includes having a neuropsychological evaluation. And then we can say in the state, well, how soon can you get that? And it's very hard to get it quickly. So so we find ways to work around if we can't get a neuropsych immediately, because we can begin to hang on a second. There was a question. Will you be talking about the training that you spoke about earlier again regarding working? Yes. So the answer to that is yes, I will. So I want to have time for us to do that. Would that be good? So, okay. So the training, this developmental cognitive approach, is kind of what we build everything around. So it uses the development-based cognitive building blocks, which you talked about. One of the important components is this thing called errorless learning, where you find a sweet spot of where what you're working on is not so easy that they just get bored, or it's not so hard that they give up. And then you need practice, so people like in shelters and things like that, or wherever people are, can build in a way to begin to practice some of these things that they're working on. It can take up to a year of practice. And then you want to develop strategies. They're called metacognitive strategies, where you're teaching people how to think. And that's where, staff and family come in. And then you begin to help them generalize the skill to other activities, and then you keep evaluating and you manage the psychological issues that come up, which can be pretty profound. At times, if people are being suicidal, or if they're disinhibited and angry, or if they're getting really depressed and refusing to go out, or they're getting isolated. So this is basically what I put it into the building blocks component, and you've already seen this in the other slide. But this is on a in a pyramid focus. So, but alertness and stamina, we've talked about attention and processing speed, working memory, fluency, and executive functioning. So it really is the thing that makes us really human is this part about executive functioning where we can plan and analyze and then kind of talk about if it worked or not, then redo it, as well as being compassionate. And so, but executive functioning really is on top of all these other skills that we need. So, and it's just to be, awareness is one of the things that's really important, but there are these things that get in the way of being aware of, did you have a brain injury or not, and what to do about it. So there's this neurocognitive issue that happens. And that's a global impairment, results in problems with reasoning and abstract thought, and domain-specific impairments are difficult to perceive and recognize. So these people aren't like faking it, they're not avoiding it, they're not just upset, they really can't get it. And so it's really important to have that diagnosed so that you're not just, so that you're not thinking that they're just not wanting to do it or not, or, you know, that they really have a reason why it's not sinking in. The other two is a psychological denial. To avoid the emotionally painful thoughts, direct confrontation is discouraged. So you can't tell them, it's a brain injury, I can't believe you can't do this anymore. That's what we say we don't want to do. So you want to do things that develop hope and that can help. And then social environmental, it can be the lack of education, information about brain injury. And so you begin to educate people on why this is happening, and that helps. So this is just a really busy slide. And it looks at all the different types of evaluations a person with a brain injury can and might need to get. And so different types of models ask for different types of evaluations, but I just go with the graduate school response of all the above, because depending on what the injury is, you might need any of these types of evaluations, and they provide really helpful information. So it's a neuropsych, speech language, communication needs, physical therapy, occupational therapy. Substance use screens is really important, and if you're having substance use issues, then to make sure you get the right therapy for that. Medication effects, because the wrong medications can cause problems. Awareness of deficits, you should always be evaluated on that. The psychological issues, neurological issues, because it's good to see a neurologist just to rule out any neurological issues. The medical, there's a long list of medical issues that can be affected. There's pain, there's the vision, and then there was something else that I couldn't see, sorry. So there's the family. You want to evaluate how the family is doing, because family is one of the essential components of recovery, because the more healthy your family is, the better chance you have of getting better, is, you know, maximizing your outcome. So if you have a family that's not that healthy, or has its own dysfunction and can't help you with the things you need, then it's important to know that you're going to need structure in the community to help you get better. If not, you can sink like a stone and things just get really bad.
Mark?
So, yeah.
Can you, Gwen is asking, can you give some symptoms that shelter workers might see in their clients on a day-to-day basis?
Yes. So I think we're here, kind of. So, so what for in a shelter, if you start at the executive functioning part, and I want to note that what we also want to be doing is we want to be screening for post-traumatic stress disorder, depression, anxiety disorders, because, and substance use, because it is true, if you have PTSD, depression, and anxiety, any of those three, you can have trouble with memory, you can have trouble with paying attention, you can be being distracted by flashbacks. And if you're in detox, you have to get out of detox first to then figure out where you stand. So I want to put that kind of qualifier on there, just so that we're not just saying, oh, it must be this. So it's you have to be careful. So in a shelter, if somebody, shelters are really interesting places. So if somebody is really saying it's too loud in here and they feel like they just had a bad hangover, but they're more than 24 hours or whatever out, you know, from detox or whatever, and it's still too loud or things like that, that can be brain injury based, where they needed to be quieter, or if the lights, and they're complaining about sensitivity to the environment, to the sounds, the lighting, or any of that stuff, that's a problem. If they're complaining about headaches, they might have been just fine and they were just doing some paperwork and all of a sudden they get a headache. The first thing I ask is, are you drinking water? If they're not drinking water, I'm like, well, you should be drinking water. But I then also ask, have you been working on this for 15, 20 minutes, maybe a half an hour, maybe an hour, and now you're done. You have this terrible headache. So you want to look at alertness and stamina and figure out what symptoms and also might be connected to that, and then how the environment might be bombarding them too much. The next step up is attention. You might be talking to them and they might, we talk about shiny objects and stuff and, distraction, the squirrel, kind of stuff. And certainly people can have ADHD coming into this. But if they really are struggling with paying attention, if they really are struggling with staying on task with you, completing the task, if they're taking forever to get it done and they're complaining about being tired and things like that, that's what attention can look like. If you ask them to do 2 tasks simultaneously and all of a sudden they're looking at you like, I can't do that, and you're like, oh, I'm so sorry, then that can be brain injury based. The next part of working memory is you might be talking to them and they might be attending, but if you just, after 5 minutes of talking to them, if you said, what did we just talk about? And they look at you funny and go, I don't know. Or if they just make it up, because a lot of times people do the head nod. Yep, okay, you bet, I'll do that, absolutely, yes, okay, yeah, got it, And you stop and go, okay, so what is the plan? And then they look at you, that's probably working memory. So then you're trying to figure out how to give them information in a short amount of quantity so that you're not overwhelming them. You might be taking more pauses or writing things down. Memory is a hard one because, as we said, it could be all this other stuff. So you begin to ask more kind of, I would say, do you remember what we talked about yesterday? Do you remember what we did this morning? Do you remember what you had for breakfast? And it could be they just aren't paying attention and they don't care, or they have PTSD, they were just assaulted, they're frightened or whatever. Or it could be brain injury that's causing that. Fluency issues, if you ask them to read something and they're trying to read and then they're really slow, or they're reading so slow that they can't quite remember what they just read, that becomes a problem. Or if you're having them filling out any sort of calculations and they're just like, I need to use a calculator, like, great. And executive functioning is the top of the list, and what you see with this, there's several different types, but if people say, yeah, I'll do it, and maybe their working memory's intact, they might not have the follow-through. And so sometimes follow-through is, I'm afraid to do that, I can't do that, I'll get hurt if I do that, I don't want to lose my kids or whatever. And so they have reasons. Sometimes, though, the reasoning they're using isn't kind of helpful, or it doesn't make sense, and they really are stuck on moving from saying I'll do it to doing it, because there's a disconnect in the brain of going from planning to doing. And that's called an amotivational syndrome. And you need to be very careful with that, because a lot of times we just say, oh, you're just being lazy, when really it's no, there's something else going on. And they can get disinhibited too. If you see people off the handles and you're like, what just happened? It could be that they had somebody who started talking too fast, or who started making demands on them in some sense and got them emotionally aroused. And instead of them disinhibiting and using their words to kind of plan their way through it, to mediate it, they just exploded because they just couldn't keep it all together and organize a reasonable response and say, you're making me angry, or I can't do that right now, or you're frightening, you're scaring me, or something. They just explode. And so you have to begin to come up with a plan to slow down the information, help them stay safe, and then help them process what they need, whether it's writing it down or having someone coach them or someone run interference with them. So that's kind of using the pyramid. Gwen, was that sufficient, or is there something else that I should be talking about?
Hi, Mark. I think that maybe talking a little bit about what shelter staff can do in the absence of having the availability of some of these treatments for them, because a lot of our programs are in rural areas without a psychiatrist, without a neurologist. So maybe what they can do in their own little way in the shelters, rather than, I just want to be realistic, I guess.
I love that, and yes, so that's I'm gonna kind of dance around that for a second. Go, that's part 2, but let me give you some things. Let me and then talk about a little bit, and let Joanna talk a little bit about Barrow's. But so let me see if I can capture that for a second. So if you don't know about motivational interviewing, there's a nice book out there by William Miller and Rolnick. From 2013 on really lays out motivational interviewing very well in a very compassionate way, which is really important. So to start with, when you do motivational interviewing, when you're working with these people, you're basically trying to help see where they are. So there's this thing called Readiness to Change. And so you're trying to ask just a simple question of how aware are they of where they're at, and then what do they want? So it's really client-centered. And then here's 4 things you can be thinking about when you're working with them, and that's acceptance of where they are, and then compassion for their condition they're in, which I know people have a lot of, and then collaborating with them on what they might want to be doing differently, and then evoking from them what they can do. So now when you think about it in this model, what happens is that if they can't pay attention well, then you as the staff might have to come up with what's called an external compensatory strategy or an environmental strategy where you encourage, you say, would you mind if I make notes for you, if I write this down? And then you might have to do the highlighting. You might have to say, here's the 3 things that you need to know, and here's what you need to do. So you're basically making like a little graph of like, when people talk to you, you're being very forgetful. So first thing is write down what they're saying, and then pick the 3 things that you have to get from what they said, so that you're helping them shape that. If they're getting tired real fast, then the staff can say, why don't we take a break, maybe a 15-minute break, we'll get you maybe some food, and then we'll come back. So that the staff then kind of does what's called a place hold, where they say, this is where we're at, and we'll come back to this. So they might have a 3-ring binder that they begin to organize into different information. We have a thing called an IMAP that we try to use. We need to make more of them. We don't have enough right now. But you try to organize things for them into a way to think about what they need to think about, and then you either help them write things down, or you encourage them to write things down. And so with working memory, it's the same idea. You slow down and you stop, and you say, okay, and then you might have to do most of the work for them. With the memory, you might begin to cue them up. There's a thing that we call playing 20 questions with them. So you don't just tell them what you just said. You say, we were sort of talking about what we're going to have for dinner and what happened. They go, oh yeah, we were talking about that. I had pizza the other night, and I should have another pizza tonight. You're like, okay. So you try to cue them up around memory, and if not, then you basically write things down again, and then you help them learn to review. So when you're talking to them, you say, we wrote this down, where is it? So they begin to practice writing it down. Now, for me, people who have memory problems get really grumpy, and they don't like to be told they have memory problems. They don't like to feel like they're being treated like a child. So you begin to try to not tell them, like, you have a memory problem, don't you remember? You try to say, okay, what were we talking about? What is it that you think we should be doing? And if you're sitting there going, we never talked about that, and that is the biggest bunch of hooey, and oh my goodness, you are making this all up. That might go on in your head, but what you say is, what I remember we were talking about is this, and I remember we wrote it down, and this is where it is here. So can we review that? So you're beginning to do some supportive work in the shelter so that these people aren't just feeling overwhelmed or aren't just flying off the handle. Were those suggestions of any use, or you're just like, no, you're gonna have to do better than that? So where are we in my ability to come up with some ideas? Is that like lame or useful or what?
No, I think that's really good. And also you had gone through a list of different symptoms that we might see, such as insomnia, and just kind of a laundry list of behaviors that we might see in shelter that might cue us to look for a brain injury.
Yes. Absolutely. And these things, now the graduate school response is that it can be PTSD, right? And so you want to make sure people are safe. If they're getting flooded, we can talk on another talk on how do you begin to help with the psychological components of these things, because you're going to need different talks to begin to kind of put together your little notebook, and people can share and have great ideas with each other. But yes, the light issues, the vision issues, the sound issues, all those things can be more related to brain injury. And there you're trying to reduce that stimulation in the environment. So,
and then we had someone asking is agitation and sort of the perception that someone might be lying, maybe changing their story. That symptom they look up for?
Yeah, that's a really difficult one. When people start saying you're lying, you're out to get me and stuff. And again, that gets related to two issues simultaneously. So one, if people are really been abused and they have some really bad PTSD and they have some paranoia to manage kind of all the stuff that's going on, and they might what's called they might dissociate. You have to look out for when dissociation starts occurring, because you're really trying to help people feel safe and help them stay within their body and stay where they are as much as they can. The flip side of that, from a cognitive point of view, is to begin to develop memory books with people, or just kind of meeting books, just notes. You know, you see a lot of people with notebooks now, and they write down what they went over at the meeting. And you begin to encourage how, if they feel that way, you go, okay, all right, so this is so there's a lot of reflection. So you're thinking that maybe what we talked about wasn't that at all, and you're thinking it was this. And you do two things simultaneously. You say, if you need to talk about these things that you think we talked about, then how did that go for you? And then you say, and from what I remember, I think we talked about this, and so maybe we should start writing things down or tracking what's going on so you feel like you have control. Because a lot of this gets into feeling out of control, and then that causes people to be really anxious and then potentially really aggressive. And you're trying to slow it way down and go, wait. So first I want to know what you think we're talking about, so I can try to remember it that way too. And then I want to see if I can be of any help, because I might have talked about something and either I don't remember that I said it that way, or I forgot, or you forgot. So you don't just look at them and go, it's a brain injury, but you try to soften it and then begin to get them to talk about what they need to talk about and then add in. So how did that seem?
Yeah, that's helpful. Thanks, Mark.
Okay. All right. So any other, sorry, I appreciate you all doing the, looking at the questions. Any other questions that we should cover? Okay. All right, so just because of time, I'm going to ask Joanna, I'm going to just skip through some of these things and have Joanna talk about some of the stuff, and then I'll come back to these things if we have time. Is that okay?
Sounds good.
Okay. Before I go, this is one of the things I want to just talk about real quick before we get to that, and this is, Erik Erikson has a wonderful model. It's called the Psychosocial Model of Development. And what we do is we focus on these 4 initial stages, which is trust and mistrust, autonomy versus shame, initiative versus guilt, and industry versus inferiority. And they're in different colors for the reason of when people are mistrustful and shameful, or feeling ashamed of things, or feeling like people are going to just tell them they're bad people, they really don't have a good connection, and they really don't then move on to take an initiative in doing things that they're trying to do that fits into the group. They really just do what they want to do when they want to do it, and they could care less, so they're not worried about what other people think. And then, so really, the green part is to remind people, when you're working with people, that if someone has a brain injury, they're not going to be able to do things as well as they think they should do it, and so you are reminding them that for what they have been through, they are doing really well, and as they get better, they will begin to start to do it the way they want to do it. But right now, they're evaluating themselves too harshly, and you're reminding them that they're doing a good job. So we go over this kind of, how do you use this sort of thinking of helping people not be so defensive. And then these are just some of the other issues of, CogSmart is something you can use in your clinic or in your shelter. It's free, it's online. It's really nice. It was developed for the military, so if you use it, we can talk about getting feedback and how it's used and what you like about it. Suicide risk you have to look for. There's the assessment tools for suicide we can go over at some point. There's depression scales you can use, and we can talk about that. There's the PTSD screens as well. Support groups are really important. We can talk about inserting support groups into shelters. We have a manual on how to do that, and we can support that. Narrative therapy is real important, but that's a little beyond this talk. But that's helping them tell their story, and there's two ways you tell your story. You tell your story in public, and so that's where you have to know who your audience is and what the purpose of the story is. And then you tell your story in private, and so you're talking to somebody about how you're going to tell your story. So if you're a staff and you're helping them practice tell their story, they're going to say things, and you're going to be like, that could be helpful, that could not be helpful. So you begin to help them filter and build an appropriate story. So this is the Barrow Neurological Institute, and Joanna's going to go over what they're doing in Arizona and Phoenix. So Joanna?
Hi, everyone. All right, so the Barrow Clinic is an absolutely incredible clinic that was the first program in the nation that addressed the link between domestic violence and traumatic brain injury. It's located in Phoenix at the St. Joseph's Hospital and Medical Center. So created in 2012, the program identifies and treats women and men with traumatic brain injuries caused by domestic abuse. And it was created after a Barrow doctor, a neurologist, and a social worker identified a three-way link between homelessness, domestic violence, and traumatic brain injury. And the social worker, her name is Ashley Bridwell, had done work in homeless shelters, so that's where she was coming from. They found that many victims of domestic violence / traumatic brain injury suffer from a full spectrum of side effects that can lead to the loss of a job, loss of income, and eventually homelessness. In Barrow's, since it was founded in 2012, it has treated over 500 patients thus far. So I interviewed Ashley Bridwell, the social worker, and kind of one of my first questions was, how did you get funding to create this program? And she said it was not as difficult as it sounds, because Barrow already had, neurologists, psychiatrists, neuropsychologists. They had a center, they had so much equipment, etc. So they initially got a grant from the Holly Foundation, and the Holly Foundation is an organization that provides money to sort of innovative and new programming. And they got this funding basically on a working hypothesis that traumatic brain injury and domestic violence was a problem and nothing was being done about it. There, up to this point, was very little research done, very little literature on the link between domestic violence and traumatic brain injury. And I asked Ashley, how did you possibly get this funding without having, any literature to base that on? And they said that their hypothesis was that traumatic brain injury from interpartner violence was underreported, not well understood, or in the medical and domestic violence support community. And further, it is difficult for victims of traumatic brain injury to realize that a brain injury has even occurred, because many of the symptoms of traumatic brain injury are confusion, amnesia, loss of consciousness, etc. So basically, just on this premise, they got this $150,000 grant from the Holly Foundation, and they instituted this program. Now they run on donations, both private and public, grants from local philanthropic organizations, and they also received a massive donation from the Super Bowl organization. The year that the clinic was founded, the Super Bowl happened to be in Phoenix, so that was really good timing. And they are also funded in part by Medicaid. Okay, so they, over the course of about 3 years, wrote this incredible study and published it in the Journal of Neurotrauma. It's the February 2017 issue, volume 34, number 4. And this study, let me move this box. Okay. And so they did a retrospective chart review of 115 patients with a history of head trauma due to domestic violence. All patients were seen in a subspecialty traumatic brain injury clinic, at which time information regarding their histories and self-reported symptoms were recorded. The results were that 81% of patients suffered too many head injuries to count, 21% had sought medical care at the time of injury, 85% had a history of abuse in adulthood, 22% had experienced abuse both in childhood and adulthood, 60% of the patients abused as children went on to be abused as adults. Headache was the most common chief complaint. However, on a self-reported symptom severity scale, behavioral symptoms were the most severe, and psychiatric disease was present in 84% of patients. So this study really, put in the forefront this massive problem that's totally underreported, misunderstood in the community, and has really helped Barrow get, a ton more money to do what they do. And this is what they do. There's three components. The first is so Barrow trains staff at domestic violence and homeless shelters about symptoms and management of traumatic brain injury. So right now they work with 5 domestic violence shelters and homeless shelters in Maricopa County, which is where Phoenix is. And they use what Dr. Pedrotty was talking about, a very simple screener called HELPS. I'll briefly go over that again. H, have you been hit on the head? E, have you sought emergency room treatment? L, have you experienced loss of consciousness? P, have you had any behavioral problems? And I can go over a few specific questions. For example, have you been having trouble concentrating or remembering things? Are you having trouble finishing things you start to do? Have people told you that you're not acting like yourself? Have you been having trouble doing what you need to do at work, school, or home? Are you having mood swings that you don't understand? Has it got harder for you to function when you're under stress? Does your partner use any of these things as an excuse to abuse you? And then S is sickness, so this is more physical problems. Have you had any physical problems since your partner assaulted you? What kind? Do you have any recurring headaches or fatigue? Have you had any changes in your vision, hearing, or sense of smell or taste? Do you find yourself dizzy or experiencing a lack of balance? And at these domestic violence and homeless shelters, if a patient or person answers 2 or more questions positively, then they are referred to Barrow. So only 2 questions out of those 5, and they're referred to Barrow. So continuing with the medical component, patients are evaluated by a neurologist who specializes in traumatic brain injury. And beyond that, Barrow offers diagnostic services, physical therapy, neuropsychology, speech therapy, and injury prevention education. Also, patients connect with a social worker who not only helps them to navigate the healthcare system, but guides them in the hope of returning to a productive and healthy life. A second component of Barrow's program is community outreach. They founded something called the Brains Club, and what that is 4 speech therapists provide group curriculum education to shelters on frontal lobe function. I know Dr. Pedrotty touched on a lot of this, but memory, attention, executive functions, etc. So that's both education, self-assessments, and compensatory strategies. And basically, it's really simple what they do. They provide backpacks to tons of women. Over 900 have participated in the Brains Club since it was created. These backpacks include day planners, binders, pill boxes, and writing tools, so highlighters, pens. And those day planners were specifically picked out by the speech therapists. They think that the form is the best, it's the simplest, it's the most understandable, the easiest to use. So even just this simple backpack helps these victims of traumatic brain injury tremendously. The third component of Barrow's program is research. So I obviously went over that incredibly important study that was published in 2017. Last fall, so in October, Barrow submitted a second manuscript to the Journal of Neurotrauma about the effects of speech therapy on this population. So that includes the Brains Club that I just went over. And Barrow is also working on setting up a brain bank for victims of domestic violence. This would be the first of its kind. There are brain banks for, athletes, but not for victims of domestic violence. Alrighty, Barrow also offers police training. So they provide a 40-hour trauma-informed training program to the Phoenix Police Department on the correlation between domestic violence and traumatic brain injury, specifically signs and symptoms, causes, and post-traumatic amnesia or other memory problems. So, as we've been talking about a little bit, the brain doesn't immediately recognize that trauma happened, that something happened, and it's incredibly important for emergency responders and police to understand that just because someone says this didn't happen, it still could have. And here's just some information for you. That's Barrow's website on their domestic violence traumatic brain injury program. And that is a link to their study, their 2017 study. You have to pay for the full text, but it's really fantastic and something that you might be able to use in your clinics and shelters, at least to educate staff. So, how do we get to the chat?
Set the party, are we? Okay. It shows up when you do something here. Okay. All right. So yes, you can get a copy of the PowerPoint presentation. Yep. Okay. In the suicide slide. Okay. So yes, we can go back on the suicide slide and. Oh, okay. And then Shinmoto is introducing a 40. Wow, that's fabulous. And then there was a question about lying and agitation. Yep. Okay, so I'll go back to the suicide slide, but are there any questions specifically about Joanna's presentation at this point? Okay, ready? So if there are, just, chime in. All right, so.
I'll let you sit here so you can get that to you.
Okay, thanks. All right. So let's go, two things. Let's do lying and agitation, because yes, these are, is that the part we already talked about with, is that similar? Should we talk about that? And then what can we do in the absence of having to?
Yeah, you did address that.
That's what I thought with the paranoid and, you're lying to me.
Mm-hmm.
Yeah. Okay, and was that sufficient, or were you like looking at me going, God, this guy, he just does not know? Or both. You can say both actually, but how was that?
Had to ask that. I don't see any follow-up.
Okay, so if Roberta's out there, if you don't mind us, singling you out, because we don't have like the Hollywood squares where we can all look at each other or something, but well, I don't. But if you don't mind, was that useful, or you're like, this person just doesn't get it. So, I mean, it might have been something I missed. So, any more on that? Okay. Depending on the medicine I'm taking, silence can be good or it can be really bad. So I took the right medicine today, so I'm not thinking like, what do you mean you're not talking? So anyway, all right, so suicide. Suicide assessment tools, really, really important. And I'll go even further here. So there's a suicide assessment, as you can see here in PHQ-9. If the PHQ-9, I think it's called the Patient Health Questionnaire, and it's free. It's out there on the internet. And the first 8 questions are about depression. And the 9th question is, have you been thinking about harming yourself? And that's why I like the PHQ-9. Some people use what's called the PHQ-2, which is just 2 questions of depression to screen. But it's important to be comfortable asking people if they've been thinking about hurting themselves. So I don't know if you've already done the trainings and things on this, but at the simplest level, you start with clarifying the difference between thinking about killing yourself versus wishing you were dead. Because a lot of people are like, I'm just such a burden to the world, I just wish I was dead. It'd be better off if I was dead. But they're not thinking of killing themselves. So then you move the question into, okay, so at times, everything is terrible. You should just go eat worms. Nobody loves you. Everybody hates me. Okay, got that. Now, do you ever get so sad that you think about harming yourself? And have you, and it's yes, what things have you done to think about harming yourself? And then you start basically doing a real kind of more in-depth safety screen, which the Columbia Suicide Severity Rating Scale is really, it's a well-done measure, and it helps you say that you actually did a nice job of covering the different areas that require a screening for that. And there is there's a webinar on it where you can get, I think you can get trained online for it, and I believe it's free. So that's also good. Safety suicide assessments, five-step evaluation and triage is useful just to kind of get through it. The suicide behaviors questionnaire is helpful. I think that might be proprietary. I have to go double check, but maybe not. But SAMHSA has this nice website that you can look at this stuff. But the point is, you want to slow that conversation down and begin to talk about how are they safe and what have they been doing. So what else should we talk about? Because it's unfortunately it's near and dear to my heart, and you know the rule with suicide is if you can buy 48 to 72 hours of, or 24 to 72 hours of time, most people who are suicidal are no longer that way.
She says thanks, got it.
Okay, so you just needed me to go back to the slide so you could see it.
I think so, yeah.
Oh, I'm sorry. You could have been like, put up the time, like, no, don't talking. So sorry. All right. So we have some time left, right? So there was a slide in here somewhere. And Gwen, maybe we can begin to talk about this idea of the planning stuff.
Hey, Mark. This
Yeah.
is Joanna from the Coalition. So
Yeah.
some of the resources that you're sharing, like these scales and things like that, is this something that, you know, like advocates can, not just clinicians, but like can advocates and all different professional levels use these tools?
You know, I think people who are paraprofessionals can be using them. So they don't have a set, like you have to have a PhD for them, because they're out there on the internet and it's a general kind of a paraprofessional, but you should have some training and supervision on it. So if you are going to use this, like for suicide's such a kind of a difficult concept to be topic to deal with, because you want everybody in the community to feel comfortable talking about suicide. Then when you get into who's going to assess the risk of suicide, then you have to kind of look at the agency and how the agency is able to protect itself and what it's able to do without getting into trouble, liability issues. And that's something that I think I would have to talk about more, about how each agency either has a training component and how it keeps people up to date in its skills, and or if it's better just to do a really simple screen that says this person needs to be seen by somebody, or the police need to go do a safety check. So it really is important just to know what the resources of the community are and what their liability kind of support is, and how they want to begin to manage that so they don't put themselves at risk, if that makes sense.
And Mark, just to add to that, this is really something that we're going to have to get some training on, because we know that women who have been abused have like a 12 times rate of suicide than those who have not been abused. So we're looking at a population that we work with every day that has a very high risk of suicide. And especially in New Mexico. New Mexico has a very high rate of female suicides, and a lot of those say that they are due to relationship problems.
Wow.
Yeah, so this is something we're going to have to work on in this state.
I wasn't aware of that very sad statistic. So,
Yeah.
And I think the more we reach out and feel comfortable providing support, and then getting law enforcement, and I know this gets paranoid. I mean, it's, you know, it isn't to set the protocol up and get the training set up correctly so that the steps through it allow people to stay safe, and allow the people who are screening for it not to feel hopeless. Because the other part that you're not talking, that is connected to this issue of high suicide rate, is what does it do to the staff when they're working with somebody and someone suicides in their, you know, as part of their relationship. It's for me, I mean, when people suicide and you've been working with them, it can be potentially very devastating and demoralizing. And so it's a very complicated issue that I hope that the training you're speaking of can really be broad.
Yes, absolutely. It's devastating for everybody involved when that happens.
Yeah. No, there's nothing nice about suicide that I can think of. Oh, anyway, we won't go down that dark path.
No, not at this point.
Leave it there. Sorry. So, all right. Other things we should be talking about? Any comments about what we did talk about? Where we have. What should we do with the time we have remaining?
So we have about 15 minutes left, and I don't know if anybody, I mean, we can stop the recording. If anybody has any, someone that they've been working with, or questions regarding someone. So what I was going to say, what was leading to my previous question, is that a lot of our domestic violence programs, which I realize they're not all domestic violence programs on the call, don't have any type of someone there to do any diagnosis. So most programs don't do diagnosing. And a lot of programs don't even have an independently licensed clinician. And so I think it's important for people to kind of know what are some ways, how can they do this without necessarily being a mental health clinician when they're working with people.
Yep.